You're recording it now, so we're all set. So pathophysiology, in other words, understanding disease processes. And we'll talk about the difference between pathophysiology and physiology and anatomy and pathology. And like I said before, I love watching House. I love watching their process or their thinking process. Because if you watch that show, they don't talk about one disease. They talk about like 5 or 6 diseases that could potentially have the same consequences. And then they narrow it down. What's that called? Where you have all these symptoms and you have to, thank you, I was thinking, how do you say differentiate without saying it, differential? But yeah, differential diagnosis. And pathophysiology is all about that. It's trying to figure out what the symptoms are and then the disease from it, or vice versa. Knowing what the disease is and predicting the symptoms that are going to come about. So when you look at anatomy, physiology, and pathophysiology, it gets a little bit more complex each step. And I look at anatomy as being the alphabet and the numbers. These letters, to somebody that is a native-born Chinese person and they don't use our alphabet, these things are all just jumbled letters, just like their alphabet's different than ours. When you're learning anatomy, you're just learning the tools. It's a lot of memorization. When you get on to physiology, it's rearranging the tools, using them to your own advantage and learning how to manipulate them. So taking letters like C and T and A and actually building words like act or cat and using it, or even taking numbers and learning how to add. Pathophysiology is a little bit more in-depth because it's taking what you learn in physiology and then breaking it or making it a little bit more complex in description. So we'll start talking about that. What happens when you take an equation like 1 + 1 + 1 and you break it? You know, what's going to happen to that final product? And it's a lot about practice. Like this. If you gave this test to a second grader that just learned to read, they can't read this. But you've been reading for so long, where's this study done? At Cambridge. You don't even have to look to see the whole word. You could probably fly through this, read every single word, and it makes perfect sense for you. You understand it all. But you show it to somebody that hasn't had a lot of experience with it, and they have no idea. Medicine's exactly the same way. You were exposed to a lot of things in anatomy. You were re-exposed to very similar things in physiology. Now you're going to re-expose to it in pathophysiology. The more times you see it, the faster you are at understanding and translating it. So you already figured that out. All right, so tip number 1 is practice, practice, practice. Look at things a lot. Tip number 2 is approach things with an open mind. So when you look at something like this first picture, it looks like the guy's climbing up and out of the hole, but in reality, look, it's on a sidewalk and it's flipped upside down. Take a step back sometimes. Don't always assume that what you're seeing right now is exactly the way things are. Or like this, with a 3-dimensional drawing. This is actually drawn on a flat sidewalk, but it looks like this guy's standing on a ledge several stories up. Take a step back from things and understand, how does that work? Like this, I saw this in the way that it looks like the globe is just popping right out at you and the man standing on the top of the earth. In reality, if you take a little bit different perspective, you can see that it's nothing like what you saw initially. Pathophysiology is like that. You have to take things from different perspectives. First perspective is usually not the only perspective. Tip number 3, nothing's absolute. So when you're looking at the different pathways, here are your symptoms, here's your disease. There are a lot of different things that can lead you to that. Some of these pathways aren't even going to be the right one. When you look at symptoms like a cough or chest pain, that doesn't necessarily mean that that person's dying of one specific disease. It could be a lot of different things. You have to take that differential diagnosis and narrow it down. And all semester we're going to do that. We're going to show you the different symptoms for different diseases so you can narrow it down and find exactly what the right disease is that's leading up to the symptoms or symptoms that lead up to the disease. All right, those are the 3 basic tips. And of course, don't stop studying. Just keep reading the book. It's a fun book, and it's full of diseases that you're going to have to deal with in the rest of your life. Practicing medicine is all about maintaining health or correcting disease. So you need to know these really well. Okay, the fundamentals. So this chapter is not actually in your book. What this is kind of like terminology and overview of what we're going to be talking about all semester. So some terms like morbidity versus mortality that you have to know the difference between. What's the difference between pathology and pathophysiology? Congenital versus acquired. I'll just go through the list. Okay, so the first thing we want to differentiate is health versus disease versus illness. And a lot of times people will mix up disease and illness and think they're exactly the same thing, and they're not. So when we define health, health is defined by a lot of characteristics. The way that you are healthy as a teenager is not the same way that you're healthy as a 60-year-old person. So a 60-year-old person that has like 80% kidney function, they're considered healthy. A teenager that has 80% kidney function is considered unhealthy. So there are some problems. So there are a lot of factors that go into defining health, like psychological factors, sociological factors. Sociology is actually a factor in health. It's the way you deal with people in your environment. Psychological factors, how you deal with treating yourself, age, sex, culture, a lot of things defining it. So the definition we're going to stick with is the World Health Organization's definition. So state of complete physical, mental, and social well-being. People that isolate themselves from the other people around them are typically, they have a psychological health disorder. What are they usually considered? They don't want to talk to people, they seem down all the time, they just don't want to talk to people or associate with others. Depression, yeah. Even people like Ted Kaczynski, the guy had depression. He said that he liked being isolated because he hated society, he was misanthropic, but at the same time the guy suffered from depression. It's a social issue, definitely not a healthy, mentally healthy person. And then physically, when you look at somebody's physical health, they could have a disease but may not appear to have the disease. When you look at somebody that's ill, they appear to have the disease, and they have the disease. Explain that in better detail on the next slide. So, in this type of situation, when we define disease, disease is the actual thing that's inside of them. Either a broken process, or a virus in them, or a bacteria that's causing something. It's some kind of change inside of them. That's the disease. And illness is when they're not perceived as being healthy. So, anybody know what that guy is? Magic Johnson, what's his disease? HIV. He has HIV, but he doesn't show the physical symptoms outwardly. So he has a disease, but he's not suffering from the illness right now. Somebody told me that he was magically cured. Have you ever heard that? I've never heard of somebody actually being cured of HIV, but I guess if you have enough money, miracles can happen, right? And what's interesting when you look at what they call the iceberg theory of disease is somebody like Magic Johnson. When you look at disease that are diagnosed, it's just the tip of the iceberg. There's a lot of disease and a lot of unhealthy situations that are out there. So when somebody goes in, they get diagnosed with a disease, that's the tip. There are a lot of people out there that are diagnosed but they can't control it, and even more that are undiagnosed but actually have the disease, or people that are wrongly accused of having the disease or wrongly diagnosed. They're false positives, in other words, they talk about it. There are a lot of people that don't have the disease, but they're actually basically prepping themselves for the disease because they have these risk factors, things like smoking, working in toxic environments, right? And then the healthy population down on the bottom. But when you look at breaking down the whole population, they call it the iceberg theory. Only a small percentage of these people will actually have the disease and are diagnosed with the disease. A lot of people running around out there without being diagnosed. Next concept is adaptability, and this is the whole focus of pathophysiology. Your body's amazing. Your body's kind of like I'll just use the brain as an example. It's like a supercomputer. You have all this equipment up there that does so many miraculous things. It can do so much super fast. The difference between your brain and a computer is that what would happen if I spilled a cup of soda on my computer? I would probably fry it. Yeah, I'd short it out. If I wait long enough, will it fix itself? Nope. But if somebody has a stroke, and that stroke, sometimes it can cause temporary changes, and if you give them the right treatment and you wait long enough, sometimes those stroke symptoms can correct themselves because the brain's organic. Your brain adapts, your body adapts, your heart can adapt. People have a heart attack, and it should have killed them, but sometimes they struggle along for a little while and their heart function will come back gradually. Not completely, but gradually will start kicking back in. The rest of the heart adapts. Your body adapts to overcome problems. It depends on your age, your sex, all of those characteristics too. So when you think about a loss of a liter of blood in one person, what would happen if that one person were a child? What would you have to worry about? Yeah, shock. So at 1 liter, you're worrying about shock, worrying about it becoming fatal and killing them. But if we lose a liter of blood, we can go in, sit in line in the waiting room, and then get a transfusion and put that liter back in. So as an adult compared to a baby, or even the same person, you could have something like a hemorrhage, and that hemorrhage, they're losing blood, right? But you have to worry about shock, where if they have a GI bleed, they're gradually losing the same amount of volume, slowly. What would you have to worry about if they're bleeding into their intestines? And it's chronic. So they're not dying from it right now. What disease might you have to worry about if you're losing blood? You're losing red blood cells. Anemia. Yeah, so different problems can happen in the same systems and come out with different effects. But your body adapts. Next. All right, terminology to know. Anatomy and physiology, you already know this. Anatomy is the structure, physiology is the function. Pathology and pathophysiology are just the disease states of both of those. So pathos means suffering or disease. So pathology is talking about the disease affecting the anatomy, structural change. So you take somebody to the path lab, you actually cut it out of the person. It's not going to go back into them and grow into them again. You cut it out, you've basically sent this thing to die, and you send it to the lab. Pathophysiology is what's happening to that living person. So what's going on with the disease in them. When you look at something like progression of emphysema, up on the top you have normal, healthy lung tissue. What are the little cells in the lungs that we're looking at? Anybody remember? Alveoli. Yep. So you're looking at alveoli, and if you remember in detail, it's a type 1 alveoli that form the walls. And then when you look at the progression, you can see what happened to the alveoli in this situation. You got huge, right? So if you had physiology before, you probably remember emphysema. All those alveoli start bursting, and they get these large alveoli. This is a dead section. This is on a slide, which means it's not going back into the person. The person's probably dead, actually. Pathophysiology is what are all the functions that are going on leading to the symptoms. So what's going on in the actual lungs? How's the lung compensating? What's happening to their breathing? What's happening to their blood flow? What's happening to their blood pH? And we'll talk about all of those with emphysema. So know the difference between pathology and pathophysiology. Pathology is the structures, pathophysiology is the mechanisms. And then the big picture, why should you know pathophysiology, is because it allows you to diagnose. So if you know the symptoms, you can come up with the disease. If you know the disease that they have, you can predict the symptoms. So back and forth. Helps you to identify or to predict. Okay, a little bit more terminology. So etiology and pathogenesis. Etiology is where it starts. So what started this thing? Was it biological function? Was it chemical function? Was it physiological damage? So physical damage, mechanical damage. So what started it all? And 3 terms, I put them in bold so you remember. Idiopathic, iatrogenic, and nosocomial. What's idiopathic mean? You feel like an idiot because you don't know the pathology, right? Idiopathic means it's unknown cause. So what started it was an unknown. Who caused it if it's iatrogenic? Doctor did it. It doesn't mean that it's an open lawsuit possibility here. It means the doctor did it usually to save your life or to change your life for the better. Like something iatrogenic. People can get hypothyroidism because they had hyperthyroidism. The doctor went in and they pulled part of the thyroid out, but they pulled out more than was necessary. Now they have hypothyroidism. Or if somebody has a tumor or a cancer in the thyroid and the doctor pulls it out, if the thyroid can't make thyroid hormones, then they have hypothyroidism. It was caused by the doctor, but not in a bad way. It was because it was in the best interest of that patient. And then nosocomial, where'd they get it? In the hospital. And then pathogenesis is the progression. And pathophysiology starts with the etiology, where it came from, but then we talk about the progression. Like today we'll talk about what happens when you just deprive tissue of oxygen. What's the actual steps or progression that cause necrosis or death of that tissue. So that's pathogenesis. Okay. So other categories, genetic, congenital, and acquired. Genetic means who'd you get it from? Yeah, parents. So it's passed down from mom or dad. Congenital means that when mom and dad passed down, so the egg and the sperm were all intact genetically, they had the right things going on. Congenital means that something happened to the genes in the process. So maybe you got the good sperm and the good egg, but as it's starting to develop and split, something happened. A mutation happened and it changed something. There are 2 types of congenital diseases. We can refer to them as anomalies or malformations. So anomalies are just weird things, like being born with a 3rd nipple or an extra thumb. So that's not life-threatening, it's just strange. It's an anomaly. Malformations are when it's life-threatening. So if you have a heart valve that doesn't shut completely, that would be considered a malformation. It's potentially life-threatening. When we talk about genetics, we'll talk about some of the details. Like you can get the right genes from the parents, something could happen like a mutation. what's also interesting is that even if you have the right genes, sometimes your environment can actually affect what's going on with those genes. So the environment can turn on or turn off the genes, and it doesn't work appropriately anymore. And so we'll talk about that in genetics. This is a big topic with breast cancer too, because there are a lot of people born with a flawed gene that causes breast cancer, but they never get to breast cancer because of their environment. And the next one, acquired diseases. So acquired is something you get after you're born. Oh, I forgot to mention this. Typically, malformations have a special name called a birth defect. Anomalies are just weird, but a malformation is actually a defect, and it's a life-threatening situation. Okay, so how do we describe the pathogenesis? Was the pathogenesis what caused it, or the progression? It's the progression. So, as you go through and you look at things, usually you can see morphological changes, which can overlap with pathology. So when you look at structural changes, it can be anatomical, which is pathology, but at the same time, it can cause physiological damage or changes. So the example of blood vessels, up in the top corner, you can see a normal blood vessel, nice open lumen. And then you start depositing fats along the edge, it causes morphological change. You start accumulating those plaques, your immune system starts attacking the plaques, and it just causes one problem after another after another. And we'll talk about the pathogenesis of that, how each of these steps happen too. But they cause these changes. If you, in the United States, if you had a 5-year-old that died and they did an autopsy on the 5-year-old, you'd actually start seeing these plaques developing in a 5-year-old because of, well, what would be the primary driver of a 5-year-old in the United States having plaques developing in their heart and blood vessels? Yeah, so the diet, things like McDonald's and fast food and the way that we eat highly processed food. But these morphological changes are constantly happening. When it's in that 5-year-old, I'm assuming they died from some other cause, but it's preclinical. There's no actual symptoms because of the deposits, but the deposits actually exist. Other diseases are like that too, like hepatitis. So if somebody can get hepatitis, but they're not showing it. What's the bad thing about the preclinical stage that they're not showing it, but they have like a virus? What could they be doing? Spreading it. They have no idea they have it, and they can spread it from another person to another person to another person. What do you call those people? Yeah, carriers. When you got tested before you even started at Mercy, they did a TB test just to make sure that you didn't have TB or you weren't a carrier. Because not everybody that has TB in their body is actually showing the physical symptoms of TB. Oh, sorry, I forgot I listed the different stages. So, in the latent stage, latent means that it's kind of idle. So the disease is there, but there's nothing really happening as far as symptoms with the person. They have the disease, it's just hanging on there. When they go into something called the prodromal phase, they start getting these really weird symptoms, like mild symptoms. And they be things like headache or a mild cough, or they just feel weak. But it's before the intense symptoms that actually drive them to the clinic. Sometimes they stay in this phase and subclinically. They never actually have to go to the clinic because it never gets bad enough. And a lot of times hepatitis will do that. So hepatitis stays at this mild stage for a long, long time. They keep spreading it, but they don't have the physical symptoms. Next is the clinical. So clinical stage is what drives you there. So in a situation like a heart attack, somebody could have this thickening of the lining of the blood vessels for years and years and years. They may start getting like weakness when they go to exert themselves. They feel a little bit tired. They feel, I just feel like I can't catch my breath. Those are preclinical. At the point where they start having chest pains and they go in, clinical manifestations. And there are 2 major categories you want to pay attention to: the symptoms and the signs. So symptoms are subjective. What does that mean? Subjective means that it's something that you're telling the doctor. It's not measurable, like pain. You can't measure pain then. People say, I'm in this much pain. But if you give 2 people the exact same painful stimuli, they may rate it completely differently. It's subjective. Can people fake subjective symptoms? Absolutely. People can come in and say they're in pain so they can get drugs or something like that. People can say they're dizzy, I feel weak and wobbly, or they can act like they're having a problem breathing when they're doing just fine. So subjective symptoms can be lied about. And then signs are objective. They're things that can be measured. Like if somebody says that they're feeling hot and they're running a fever, they bend over and you shove a thermometer in the butt. You got a measuring stick. Right? You can see swelling. You compare the left and the right ankle, and you can see swelling in one. You know it's a sign. It's objective. Okay? You test their responsivity from the pupils, and you know that it's actually happening. You can't fake those things. So symptoms can be faked, signs can't. And complications are just adverse side effects that happen from the disease. So what we'll find is that anemia is usually not the actual disease that's the problem. It's usually a complication of something else. Like people that are struggling with cancer and they're getting chemotherapy, they may have complications because of chemotherapy that cause anemia. People that have like malnutrition causing anemia. Their body can make the blood cells fine, they're just not giving it the raw materials. There's complications of other situations. And sequelae are just an order of things that are happening. So what's the order or the progression of things? Describing location. This is kind of probably a gimme, but systemic versus local. Systemic means the whole system. Local means it's isolated to an organ. When you're isolated to an organ, you can say focal or diffuse. So somebody can have a focal lesion on their liver, just one area of the liver that's necrotic or damaged, or they can have diffuse damage, like cirrhosis of the liver that affects the whole liver. So we can define and subdefine. Right. And the differential diagnosis. So typically when you're doing a differential, you have a syndrome. So all of these different symptoms or signs that come with this disease. Like warning signs of a heart attack, pressure in the center of the chest discomfort, sweating, nausea, and fainting. Does that mean that they're having a heart attack? You ever get ghost pepper? It's hot. It causes pressure in the center of the chest. When I've eaten them, sometimes I get the hiccups. I start sweating like crazy. Sometimes I get a little bit nauseous. Sometimes I feel like I just want to sit down because I feel a little lightheaded. If you've ever eaten the actual pepper itself, it can make it look like you're having a heart attack. So, pain in the shoulders and the neck, I've never had that intense though. I guess if I rubbed the pepper all over my shoulder and neck, it would do it. But a lot of these symptoms are a lot of the same. And we're going to see, like when we get in the skin, almost every skin situation has a rash, period. But it doesn't tell you what the problem is. So you have to learn to identify the different symptoms. And sometimes it's that one or two symptoms that make that disease different from the others that you want to focus on. Instead of remembering, like if you go to WebMD and you look up heart attack, it'll give you like 15 or 20 symptoms. But if you go to the next thing that's like heartburn, it'll give you 10 or 11 of the very similar symptoms. It's the ones that make it different you really want to focus on. So a lot of them are common sense, but focus on the things that are abnormal. Don't make life too difficult for yourself. Okay, so differential diagnosis. Once we know what the disease is, we can do prognosis, so we predict what's coming next. What happens here, here, and here. So if we know somebody's having a heart attack, we know what's going to happen next. What's going to happen in the blood, what's going to happen to the heart tissue, what's going to happen to their circulation, and we can give a prognosis. And then, of course, therapy is the treatment. And I'm kind of moving through these because a lot of these you've probably seen, but I just want to make sure you know some of the terms. So there'll probably be a few of the terms that you go, oh, I forgot that, or whatever. Right, the evolution of the disease, when you get the disease, you can have acute, which means it does what? It sets in very quickly. Yeah. When you look at acute and chronic, you can have the same disease. When you have the acute version and the chronic version, usually the symptoms are exactly identical. The only difference is how fast they set in. Like when you talk about different types of leukemia, which we'll do when we get to cardiovascular, we talk about leukemia, acute leukemia, all the symptoms come flying on within days to weeks, where in chronic it can take years before the symptoms all get to their peak intensity. Right? So acute and then chronic are the extremes, and subacute is just in between. And with chronic and continuous, or chronic continuous, usually you see things like exacerbations. When we talk about multiple sclerosis, we'll talk about that. So with MS, multiple sclerosis, people have their symptoms and then they seem like they're okay for a while, and then they'll have this exacerbation where it's really bad symptoms. They get pain, they get blurred vision, they get weakness, maybe a little incontinence, and then they start getting a little bit better, and they feel like they're better, and they go into a phase called remission. Usually with diseases that are chronic, you see complications. So it starts affecting the other organs. Something like emphysema, it affects the lungs, but at the same time, they're not getting enough oxygen into their circulation, so it's going to affect every other system. You're going to find complications. So neurological problems. With emphysema, another complication is acidosis. Anybody remember why? Or guess why? Why acidosis? What are they having a problem getting rid of? CO2, exactly. So They accumulate the CO2 and it causes these secondary complications. All that acid in their body starts causing the brain to misfire. It starts causing them to feel weak and tired, causes muscle imbalances. And we'll talk about all those too. So like I said, these are just general overviews. When we get into the diseases, we're going to come back to these terms again and use them more specifically. Next major concept is epidemiology, and it's just the study of the disease. And I was going to play a game, but I decided against it. The first epidemiological study was actually a doctor named John Snow, and it was on cholera. In Great Britain, they had this huge cholera outbreak, and he noticed patterns of where the disease was spreading. And he found that if he looked at where all the people were at that were getting the most cholera, right in the center of it was a well. And he went to that well, and he found that all the people were getting water out of the same well. So what he did is he took the handle off the well, and guess what happened to the cholera outbreak? It started lessening up, getting milder and milder and milder. You know what the best treatment for cholera actually is? Clean water. Yeah, that's the best treatment. Because they get diarrhea, they start losing body fluids, and they die of dehydration. So, getting clean water. When they were forced to go to clean wells, they were getting better. It's kind of an interesting process. And that was the first epidemiological case, was this outbreak of cholera. Two terms that get mixed up a lot: precipitating and risk factors. Precipitating factors cause the disease. So there are things about you that are actually causing or provoking the disease. I'm trying to think of a good example. No one example comes to my mind, but I have a slide that we'll talk about. Where risk factors are things that contribute to it. So smoking could be a precipitating factor for what disease? Lung cancer. Yeah, it's the main precipitating factor for lung cancer. But it can also be a risk factor for things like high blood pressure or heart disease. So not everybody, and I guess it's kind of a tricky one because not everybody gets lung disease either, but risk factors are just things that increase your risk for the disease. Precipitating factors actually cause it, or the causing factors. I'll give you a couple examples coming up here. So like this. Precipitating factors for heart disease. So adenomas can cause it. Is this in your notes? I couldn't tell when I heard all the paper flipping on this. I didn't know if it was, oh my God, where's the slide, or if it was the next page. But things like polycythemia, thick blood. Why is that going to cause heart disease? Yep, it has to work harder. Your heart, if it has to work harder and harder, it's like driving your car with the accelerator all the way to 4 all the time. What's going to happen to your engine compared to normal people? It's going to wear out faster, right? So some of these things, precipitating factors, are actually causing the disease. Or diabetes causes heart disease. If you have diabetes, it's one of the top risks is heart disease. You have to worry about neurological disorders. We'll talk about that with diabetes. Other things like risk factors. I just mentioned one risk factor. It doesn't necessarily cause heart disease, but definitely contributes to it. Smoking. Yeah, so smoking contributes to it. Diet can contribute to it. So those are just some risk factors, things that increase it. So while we're talking about epidemiology or disease spread, two other terms, incidence and prevalence. Incidence is new cases. So how many times it hits in a year, or I guess you can do it by month, or by 6-month periods. How many new cases you get in a certain amount of time. Well, prevalence is how many of those people are still living. So if we just came up with this new disease this year, and over the next year we have 5,000 new cases, and then next year, 4,500 of those people that died, the prevalence would only be 500 out of that. The next year, another 5,000 cases pop up. You've got incidence of 5,000 this year, but what's your prevalence in that next year? 5,000 and then 500. Those are the people that lived through it and held on. Sometimes incidence and prevalence, we're going to see it on a chart. When they're talking about a treatment for something or curing something, when you look at a disease, you look at prevalence as being the little diamonds. Prevalence are the people that are still alive. Incidence is how many new cases. So what do you know about the incidence from 1995 to 2000? It's a decrease. So what's that telling you? So yeah, so some kind of a preventative medicine or preventative treatment is working a little bit. It's reducing the number of people that are getting the disease. What do you know about the prevalence? It's going up steadily. So what's it telling you about the people that have the disease? They're living longer, so our treatment's working. So usually when you see a graph like this is talking about preventive medicine, and up here talking about treatment. What are we doing right? We can measure these different things. And when I was taking a biology class a long time ago, I remember seeing this funnel effect. The estimates are all the new marbles that are going in the jar, where the prevalence of how many are still alive in the jar are still in the jar. And of course, death is going to take out of that equation. So here's just an example. When they're studying new treatments or preventative medicine, what they look at are the predicted values. So you can see the prediction of where they think this disease is going, and then they introduce some kind of treatment or preventative medicine, and they look at what's actually happening. So I think this is a prevalence chart. New HIV infections. So what's the new HIV infections? Incidence, right? So in this situation, they were probably doing some kind of a like public service announcement or informative instruction for people, and apparently it must have worked because it dropped the number of cases under the predicted value. So prevalence and incidence. Here's another one. So this one's prevalence. What's interesting was when you look at the maps of prevalence of obesity and diabetes, where people are living, I guess it sucks to live in. Okay, thanks. My geography is terrible. So when I was talking about all of my friends with my medical knowledge, that's all I've got. Drained. I do trivia. I used to do trivia with my friends. And it's funny because anything that was science related, I rocked at it. Or if it had to do with music, I was awesome. But you asked about presidents or geography, I'm screwed. Yeah, I'm out of it. Or pop culture, baby, good job. Come on. But yeah, you can see some of the places we overlap. What's kind of interesting is that as things have progressed, it was pretty uniform across the whole nation back in 1990. But then just over a decade and a half, you can see the growth of obesity and diabetes, and they grow pretty commonly across here. So I guess the good thing is that we're helping people live longer with obesity and diabetes, so reducing the risk of heart disease from obesity and deaths from diabetes. So when you look at the outcome of the disease, you can have mortality and morbidity. Mortality is when it kills them. Morbidity is when it causes them major dysfunction, as it's compromising their ability to live their normal life. So some of the diseases, things like diabetes, can have both morbidity and mortality. So morbidity, people with diabetes might lose a foot or a limb that keeps them from being able to work or function appropriately. For mortality, what did it do to them? It completely killed them. It took them out of the population. So some diseases, like I said, diabetes can have overlapping mortality and morbidity. Some diseases, like arthritis, you don't hear a lot of mortality. Yeah, he was suffering from a joint attack and it killed him. But it creates a lot of morbidity. It actually causes a lot of dysfunction and makes so people can't function in their daily life and affects their way of life, period. So I looked this up, and this is the most current chart I could actually find. But when you look at things like the leading cause of death, are we talking about morbidity or mortality? Mortality. And you see heart disease, neoplasms like cancer, strokes, CVAs, are the leading causes of mortality. But when you look at the leading causes of morbidity, arthritis is actually at the top. So heart problems, they can't exert themselves normally. It didn't kill them, but it made their life a little bit harder to live. So there's a big difference between mortality and morbidity. And I just threw this in. Disability adjusted life year. This is when they take both of those charts and they look at it all together and they figure out what diseases actually cause the most of both, and they find cardiovascular disease is actually the number one cause of both morbidity and mortality situations. Neoplasms number 2, respiratory disease is number 3. So morbidity, mortality, and then being able to mix them. All right, winding down. The last major topic is actually natural history. So natural history of a disease is when you look at a disease and you watch what happens without treating the person, without affecting their life, and just sounds bad, but basically you're letting them have the disease and letting them die. Is that ethically possible anymore? No. If we know of a treatment, we have to give the person the treatment. But in some cases, we didn't know really how to treat the disease, so we actually progressed or took notes on how people died, which seems, like I said, morbid. But what happens is the natural history is that They get the disease, we watch it happen, and then we watch them die. Back in the early 80s, there was a disease that started popping up all over the place, especially in the United States and in Africa. And in the early 80s, it was known as GRID, gay-related immunodeficiency syndrome. And we had no idea where it came from. We had no idea how to treat it. We didn't know what the heck was going on. So basically, they saw people get this disease, they watched them progress through it, and then we watched them die. What do we call it nowadays? AIDS, right? So it's HIV is the disease, and then it progresses into the illness, which is AIDS. So we know the natural progression of HIV and what happens to people. So we can introduce some treatments, and then find out, did it prolong their life? Did it slow down or ease their suffering? Did we cure the disease? So natural history is when we don't do anything to the disease and just watch what happens. Hepatitis C is one of the diseases that we're still kind of like that. We really don't have an effective treatment. We have a lot of things we treat to help people, but there's no actual cure for it yet. So some cases, we just have to watch people go through the progression and die because of the disease, and we can't do anything for them. What's interesting is that not everybody that gets Hep C actually progresses and gets cirrhosis of the liver. Some of these people, they go through it, and it's almost like they're immune to it. They carry it, but it doesn't affect them. And we're trying to figure out what's going on with those people. So that's natural history. Next are the 3 levels of prevention. And prevention is kind of a misnomer because the first one is true prevention. Primary prevention is when we immunize somebody. We give them a vaccine and they don't get the disease. But secondary prevention is when we're trying to early diagnose it. So they may have the disease and we're trying to identify it right away. We're not really preventing anything. We're not giving them any pill to try and prevent them from getting it. We're not giving them educational materials to try and help them wisen up about how to avoid it. Secondary prevention is just identifying. So doing a pap smear, we don't know if maybe the woman has HPV, but what we're going to do is we're going to watch and see if she's going to have abnormal cell development. When we get to cancers, we'll talk a lot about that. But that's secondary prevention. Just doing these checkup tests to see if they've been exposed to something or if they're having problems. And tertiary is when we know they have the disease, then it's actually helping to treat it. So let's say that primary prevention, they get, now I'm having a brain fart. What's the name of that vaccine for HPV? Thank you, Gardasil. So that would be primary prevention. Secondary prevention is if they get HPV, then we don't want it to lead into what? What's the problem? Cancer, cervical cancer. So we do a pap smear just to make sure they're not getting cancer. And then tertiary is if they're identified with the cancer and they have the cancer, we're trying to give them treatment so that it doesn't spread. We're trying to cure them of that current cancer. So 3 levels. And then evidence-based medicine. Simple way to look at evidence-based medicine is that all of the research we've done, all of the clinical examples we've documented, we look at all those situations, we look at the progressions, we look at the treatments, we look at what's most effective, and they make this algorithm. If a person walks in with this situation, then you do this for them. And that's everything that evidence-based medicine is about. It's making the treatment and the progression better. So if people aren't suffering or maybe even they're able to be cured. And then when you look at pathophysiology, the benefit of knowing, again, is that you can track the progression, you can look at the treatments and help treat them. And when you look at what happened back in the 1900s, the turn of the century, the major killers were things like TB, pneumonia, diarrhea. These things were typically products that were diseases that were carried by bacteria or viruses. What have we done since the 1900s? Let's change that. We came up with that moldy thing. Penicillin, yeah, so antibiotics, penicillin, and also vaccinations. And now you can see things like TB and pneumonia. Pneumonia is still on there. TB is on the list anymore? Not at all. So in 1997, you can see the major things that are killing people are now heart disease, cancer, stroke. So a lot different. And it's because we understand the progression from the natural history of things. We can predict, we can treat, and we can cure. And I was going to do actually that Dr. Snow's example, but decided to avoid it. So it's 5 till 2. Take a smoke break. Smoke them if you got them, whatever. And I'll see you back here in 5 minutes. And when you come back in, I have the next set of handouts.